Good afternoon and welcome to the Independent Scientific Advocacy Group weekly meeting. This week we have seen the not very surprising decision by the government that we aren't ready to reopen indoor hospitality in the context of the Delta variant and the lack of preparation to make those spaces safe by government and authorities. And we are facing the reality of the government's wait for the vaccines strategy and live with the virus policy. And we're going to look at that in detail today in terms of what does it really mean to live with a virus and what is endemicity and what are the alternatives. But as usual, we will first start with our situation update. And for that, we have James. Thank you, James.
Thank you very much, Aoife. Did we record you? So we'll bring up the slides, please, Ben, when you're ready. And we'll start this week again with Northern Ireland. And at the next slide, please, Ben. Yeah, so we had noticed this uptick in cases in the north in the past couple of updates, and that has even accelerated in the past week, just looking at these lines. So this is daily average cases per 100,000 by different line colours or age group, and the black line is the population average. So the younger age groups are the top two lines at the top. They're rising fastest, and green line there is 40 to 59-year-olds, and even there's a little bit of an uptake even in the largely vaccinated older groups at the bottom too. So this is the indoor dining open in the north, and the Delta variant, and a combination of all those things we'll be talking about today. So if we go to the next slide, please, Ben, and I think it's useful to see Northern Ireland in the context of Britain as well, and the United Kingdom more broadly. It's really sharp acceleration, sharply rising in Northern Ireland, but even a faster rate in Scotland and England, and Wales at a similar level to Northern Ireland. So this is population weighted confirmed cases per 100,000. There's multiple things to say, but one thing to say is that there's been blowback against some of the modelling results in the Republic the past few days, but this sort of sharp rise we see in Scotland shows that what comes down the line with the Delta variant and enclosed spaces without the kind of appropriate mitigation measures in place. When indoor dining opened in Scotland and in England, Britain was a similar vaccination rate to what we have currently here. So this, I think it's useful context. We don't have to rely on abstract models so much. We can kind of see across the water what's been going on. Next slide, please, Ben. And this is the Republic. This is just absolute number of cases, and the actual, since last week, the 7-day average has, in the past couple of days, the 5-day and 7-day. This is the 7-day. This is the 7-day rolling average. But it's the 5-day and the 7-day have ticked up in the past couple of days. So the sort of decline we saw 2 webinars ago, we talked about the decline. That's halted. It kind of went along a certain level, and it's uptick again. So we'll be keeping an eye on that, and so that's where we are, and kind of facing into the next few weeks. I will be facing, and so in the Republic, the top line here is split out by age groups, and the most important striking thing here is same as last week. The red line on top is the 19 to 24-year-old age group. So that's the age group where the cases largely are, or predominantly are. The next slide, please, Ben. And so there was just the government's vaccine update yesterday. So it was the good news was it was a record week, and like in my own family, there was first and second doses, multiple trips to vaccination centres, and probably lots of people had that experience last week. So it's great. And these percentages have jumped considerably in the past week for both one dose and fully vaccinated. But as we see, this is still a good bit away from the higher percentages we need. And it's also very important to note that this is for adults. the percentages quoted. So we're at 41% fully vaccinated. So progress, but a long way to go. And as we've been saying for many months. And the next slide then is just to give some European context. This week on the international front, and just to give a context of Ireland. So our cases, this is population weighted average cases again. So in the Republic, it's higher than the European Union average. I can see Germany is lower than the average. France is not shown here, but is around the European Union average. Portugal is interesting to note because it's a real Delta variant story. Unvaccinated tourism seems to have brought the Delta variant into communities there, and there's been a sharp increase in Portugal in recent weeks. So so that's the situation update this week. I think that emphasised that point that if you don't take, as it was the same with the school story earlier in the year, if you don't take, that was literally a little tidbit that the school, there's more students isolating in England now than there have been since schools reopened in March. So it's the same story that if you open these indoor spaces without mitigation measures, whether that's serial testing, ventilation, vaccination, it's very predictable what happens case-wise, and then how that translates into everything else we'll be discussing. So thank you.
Thanks, James. That's very useful as ever. I think, a few of the points you've made there that, the models, we might sometimes discuss the various parameters of the models, but we can see what's happening in the UK. And I think Scotland is a rather startling example because there are cases that graph is rather startlingly sharp and in its upward trajectory. And also just the little reminder to everybody that Ireland actually is worse than average in Europe. I mean, in terms of case numbers at the moment, a lot of people are asking, why aren't we doing the same as our European neighbours? Well, they have sometimes better resources, often better resourced health services, one that hasn't just experienced a malware attack. And also we have high case numbers and we have a lot of Delta. So all of these things need to be factored in. So thank you very much for that, James. Now for the meat and the bulk of today's meeting, we're going to hear from Professor Jerry Killeen. And Jerry, of course, has extensive experience in managing real world epidemics with his experience with malaria around the world, and, is a huge authority on what it means to deal with an epidemic, what it means to try to live with an endemic virus, and what the alternatives are in terms of trying to eliminate it. And that's what Jerry's going to lead us through today. Thank you, Jerry.
Thank you very much, Aoife. And I think a key part is that I work on a few different diseases. Some have been pandemic, some have been epidemic, but most of my usual focus is a staunchly endemic disease. And also it's not just the science, which there's plenty of, but also the lived experience. So thanks, Ben, for that first slide. And this is really kind of this is in my mind what our potential future looks like over the short to medium term. We discussed this on Monday before the NEFIT document was released, and it's basically in our own heads, what the three possible options we might have. The yellow line in the middle is what NEFIT is aiming for, which is that we sail our boat as close to the wind and hope it doesn't flip over, and we get lucky, and then we kind of get to a reasonable place sometime in autumn. The red line is what happens if our boat does flip, and epidemics have notorious tipping points. So you're either on the right side or the wrong side of that. And then the green one is my preference and our preference, which is an ambitious vaccine plus non-pharmaceutical interventions elimination strategy, like the one Israel is on and is reaching the end of. And Israel is now in basically what's considered, would be technically considered a pre-elimination phase. And all the dotted lines at the end are what happens if we don't finish it off and we have what we call residual endemic transmission ticking away. Thank you, Ben. So then in this next slide, I'm just going to sort out some definitions because people throw around words like endemic very loosely. So first of all, if something lives in an animal reservoir host, it is not endemic human transmission. That's enzootic. Okay, so like all the bats flying across Europe with rabies, they're pretty harmless until one drops into your bed. Thank you, Ben. Which does happen, but it's a rare. Thanks, Ben. And the next slide, please. And now we do get outbreaks in other animals, and we call those epizootic. So in other words, they're epidemics in animals. And those affect us sometimes when there's a spillover. Thank you, Ben. But we know how to deal with these things. We have vaccination programs for dogs, even for foxes. There's vaccine bait you can drop by airplane, and that's how Europe basically became rabies free over recent years. Next, please, Ben. And so, zoonotic spillovers are usually pretty harmless. I've had a few of those myself. I didn't enjoy myself, but at least I didn't pass it on to anybody else. However, if you share food with an animal, then you can have real crossovers, and that's how Ebola outbreaks often happen, is through with fruit bats. So next slide, please. But again, we know how to deal with these, and for severe diseases, we usually react very well. And that's a well-established art, and that's the elimination of an epidemic. Next slide, please. But you can go beyond elimination of an epidemic in a local area before it becomes pandemic, and that's what we've had to keep doing for Ebola. But we've also eradicated entire pathogens. And the last big one, the last pandemic we dodged was SARS. And thankfully, it got stopped before it got into a full pandemic phase. So thank you. And that means, so the word eradication means globally. Okay, so a very clear point about elimination. Elimination doesn't mean global reduction to zero. It means elimination from an area where there's no local sustained human-to-human transmission. And a classic example is polio, which isn't quite eradicated, but it has been eliminated from most of the planet. And I don't see any reason why the rest of us should have to live with polio as some act of solidarity with Nigeria, Afghanistan, and Pakistan. None of us miss it. Elimination is always a good thing. Next, please. And we've done it before. So here's the story of measles when vaccines were introduced. And you can see a very similar experience to what we're going through now, that really measles only really started to peter away when vaccine coverage reached very high levels, because measles is a little bit more transmissible than COVID. So you also need to reach very high herd immunity thresholds before it disappears. So thank you, Ben. So we got to really sustain suppression. Took us a while to get there, and it took us a long time of having persisting transmission before we bit the bullet and decided to eliminate measles. And you can see how high measles vaccine coverage has been over the years, but it wasn't until we bit the bullet and decided that we couldn't tolerate this persisting transmission that things started to shift. So in 2010, Europe decided to eliminate measles. It took another couple of years to really get the machinery up through the gears, and then it disappeared pretty fast. Thank you, Ben. And so Ireland has WHO certified measles elimination status. It doesn't mean that there's no measles. There are outbreaks, but they're all traceable to introductions. They all get reeled in by our public health teams, who we all ignored and took for granted until last year. And this is normal. It's regular. It's an everyday thing. And it's something to be embraced. And it's something we all take for granted because, most of us haven't had measles. Please, Ben. And so, measles transmission was interrupted in 2015, and then you've got to go through a 3-year certification phase, and then it was deemed eliminated in 2018, I believe. Thank you, Ben. An everyday thing, and it's something to be embraced. And it's something we all take for granted because... Getting some feedback. Thanks, Ben. And so Ireland is certified. Next slide, please. And the next one. Okay. So outbreaks still go on. I think this is the outbreak our 2 children got caught in on a Christmas trip back from Tanzania. It wasn't a big deal because our kids are vaccinated. And these things don't have to be big deals. So, elimination doesn't mean zero. It just means, zero sustained transmission, and you snuff out anything that does arise. Next, please, Ben. And the issues we struggled with for measles are the same issues that we're all debating now for COVID. So they're not new issues. Next, please. And so why do we go through all this? Why the big fuss about measles when most of us don't think it's a big deal? It's not a big deal for us because we're not exposed to it, but it is quite severe. And I'd just like to, if I can maybe pull in Anthony into the conversation, who's actually managed measles outbreaks, and just explain to us all what's involved and what the practical experience is for the person who's affected.
I'll tell you two stories. One is from the late 1980s. It was a pair of twin babies I managed in the Coombe, who were premature babies who'd been as sick as parrots and eventually recovered and were growing and getting fat and going home. And they came back to us about 10 days after they went home, and they both had whooping cough. And they both ended up in intensive care in Crumlin. Now, fortunately, they both survived, but they'd got whooping cough. They themselves were too young to be vaccinated. But they got whooping cough from a neighbour's toddler who hadn't been vaccinated. And all was well. They survived the experience. The second story is a child with measles I looked after who had measles pneumonia. And measles pneumonia is a viral pneumonia, and it's really, really bad, or can be really, really bad. And this child, who had been perfectly healthy, perfectly uneventful pregnancy, normal delivery, got measles at about 9 months, again, too young to be vaccinated, from a neighbour's child who should have been vaccinated but wasn't. And very nearly died, very, very nearly died, but didn't. And the third is a child I looked after more recently who had a rare complication of measles, which is called subacute sclerosing panencephalitis. And if you can imagine what rapid onset Alzheimer's looks like in a 5-year-old, that's what you're talking about. And all of these things are things that to my generation of pediatricians were familiar. They were things we had seen. I have colleagues now who have hardly ever seen any of these cases because we have effective vaccination. In this year, in 2021, every single case of measles that's been identified in the Republic of Ireland to date has been directly linked to travel abroad. So we've managed to stop measles spread within Ireland. People still bring measles back from abroad. It still affects, and it's a nasty illness, it still affects a small number of Irish children each year. But as other countries roll out effective measles vaccination programs, we can look forward to an era when we won't have measles, when people won't be looking after children having repeated seizures from measles and encephalitis, when people won't be looking after children who need ventilation for weeks for measles pneumonia, and when the long-term complications of measles that we used to see will be gone. And that is the benefit of vaccination. Vaccination is transformative for child healthcare, and it will transform COVID if we let it, and we give it the space to do so, and we do the other things that need to be done to support vaccination programs, to control case numbers while we're supporting vaccination programs, to bring us onto the green curve that Jerry has just shown us. I'll pass back to you, Jerry.
Thanks very much, Anthony. That's that's kind of a good way to shake us all up, and it kind of reminds me why I'm not a clinician, because I just couldn't cope with those kind of difficult situations with kids. And I think we're all very grateful to those of you who choose those career paths and career paths in public health. So just coming back to measles is an example of a pathogen that most of us have forgotten about or are unfamiliar with, but it's actually deadly serious. And And that slide, that first slide there, if you could show that one, Ben, the picture of the misfortunate person's tongue. So this is the first pandemic I was involved in on a personal basis. When I got my first job in Africa, it was the absolute peak of the HIV pandemic. At the time, I was 20 kilograms lighter, a little bit prettier, and a young single man full of beans. And when I shook hands with 3 people, I knew that one of them would not be around in a few years, because this is what this is the face of HIV we don't see anymore because of antiretroviral therapy. But that's candidiasis growing on somebody's tongue, and so you see people literally with mushrooms growing off them in those days. And so HIV has been around for quite some time. It's one of our newest pandemics, but it hasn't gotten any friendlier over the 50 years since it emerged. If you could have the next slide, please. It's relatively new. Thank you, Ben. Next one after that. It emerged, in the second half of the last century. And now it's gone from pandemic to being endemic. And so it's gone down from a 30% prevalence in places where I've lived to about 10%. But 10% is still absolutely whopping. And even if you're on antiretroviral therapy, the human tragedies and the difficulties that's involved in all that is really, if you've seen it face to face, it's hard to take. So next slide, please. Now, HIV, like all pathogens, is utterly ruthless. And I just want to dispel this myth that pathogens evolve towards a kind of a friendlier, cuddlier version, like people will often tell you about the common cold. They evolve to different forms if that's in their interests. Now, I'm going to go through the big 3 because they're obviously the really good examples. And these are examples, 3 pathogens that are not very friendly because it's not in their interests. And so for HIV will kill you 100% of the time if you have it and you're untreated. And that's not a big deal for the virus because it kills you slowly. So it will extend your life for long enough to mediate its own transmission. And so there's no break on HIV there's no restraint that makes it evolve towards something less virulent. So it doesn't. Next, please. And TB is one of the other big 3. And it's never been a friendly disease. The effects of TB on humans are very obvious in a lot of people's remains, going all the way back to, that's an Egyptian mummy on the right. You can see what's happened to the backbone. If we can go to the next slide, please. And, variants aren't a new thing. And variants emerging from poverty, poor health systems, chaos, war, and inequality are not a new thing. So all of the world's multi-drug resistant TB originates from Russia. And, in parts of central Russia with poor health systems, high HIV prevalence at the time, and was spread around the world by the war in Afghanistan, which facilitated quite a bit of international travel. Next, please. And TB has been around an awfully long time. It's had an awfully long time to evolve. Now, these are bones from a Neolithic infant, and the one on the left is from the inside of the skull, and you can see all that fissuring, and that's from sustained high blood pressure in those blood vessels, just eroding away at the skull, and that's what dying of chronic TB feels like. And it really reminds me of kind of what COVID must feel like, because the things that I've had that I could relate to would be things like altitude sickness or a borderline heat stroke, where your just heart is pumping and it's keep going. And it's not a lot of fun. TB has not become any friendlier because, like HIV, it has no reason to. Next, please. Again, because that one kills you slowly. Now, malaria has been around for a while. If we can go on to the next slide, please, Ben, thank you. But when people talk about evolution, this is what it looks like. Evolution is like adventures. They're great stories afterwards, but they're awful at the time. And so this little girl is locked in a struggle with the malaria parasites floating around in her blood. And I'm happy to say this little treasure got through it, and she won her evolutionary race. And if we have the next slide, please. And But malaria does spare most people that it infects. And so most kids with malaria, this is what they look like. You find them in the school ground. They're chronically infected. They're really cheerful, typically joyful African children. But if you check their blood and you take a closer look, what you find, next please, is that they've actually got tons of symptoms. And they're actually, and they're all linkable to malaria once you do a large enough study. And this is kind of like long malaria. Fortunately, malaria is treatable, whereas long COVID isn't, unfortunately. Next slide, please. And so it took us, so why does malaria take it a little bit easier on us and maybe only kill 5% of us who get it? Well, the reason is malaria needs to keep us alive for long enough to get through dry seasons. So what malaria does is it carries around 40 copies of its equivalent of the spike protein and just plays them like cards in a card game as the immune system gets to figure it out. And so it stretches out that infection for long enough to get to the next rainy season. Next slide, please. So there's a reason why malaria doesn't kill everybody that infects, even though more parasites means more transmission. Unfortunately, if you take the mosquito out of the equation and you just serial passage it with a syringe, then within a few months, you've got something like this. Basically, this is a mouse malaria, and basically all the mice drop stone dead, as soon as they're inoculated within a couple of weeks. Next, please. And so it's not the pathogen that usually evolves when we talk about endemicity. It's actually us. And so these are the red blood cells of somebody who has sickle cell anemia. Their hemoglobin has crystallized out, and that turns them into funny shapes that block in your capillaries and causes a really debilitating lifelong illness, which historically, meant a really short lifespan. Next, please, Ben. And, the map of hemoglobin in the world, of sickle cell would not exist in human populations if it didn't confer protection against malaria when you've got only one gene. So if you have one gene, it protects against malaria. If you have two, then you're in serious trouble with sickle cell malaria. The only reason it exists is because sickle cell malaria, sickle cell anemia has advantages in malaria endemic areas. And so all the people with sickle cell in the world can trace their ancestry to malaria endemic areas. Thank you. Next one, please. And just in case anybody thinks I'm exaggerating about the effects of endemic diseases, this might look like the map of world poverty, but it's actually the map of mosquitoes that have evolved specifically to feed on human beings, which makes them crackerjack malaria vectors. And it's as simple as that. It's really driven by, and so evolution is certainly not always a friendly thing. Next, please. But of course, there's so much good news around when you look for it. And I've been very lucky to be involved in the golden era of malaria suppression and even elimination from many countries. But in sub-Saharan Africa, this is what it looks like. The world that my kids grew up in is totally different from the one that they would have grown up in if we'd arrived in Tanzania 20 years earlier. And, vastly less malaria. So that sustained low-level endemic transmission. So what does that mean? Next, please. In terms of your practical experience of your life, this is what it means. So it's actually quite useful to be an ethnic minority because you can always find your kids in the school ground. It's great. But here's our little girl with all her buddies. And the way that this changed our life is that, as she was growing up, she was not guaranteed malaria once or twice a year. Instead, she was guaranteed it about once every 10 years. And so this is the age she was when she first got hit. And so for malaria, it's the kids that are vulnerable. Unfortunately, it's treatable and manageable, and that changes your experience. But if you could go back again, please, Ben. Okay. But, the issue is that that's endemic. It's greatly reduced. The incidence rate is greatly reduced at stable levels, but ultimately you're going to get it. Now, what this means for a vulnerable person with COVID, we look at the kind of incidence rate that Andrew showed us, okay? What that means, let's say you're a 50-year-old diabetic who's hoping to live another 20 years, is that you've got about a 50-50 chance that COVID's going to find you over the course of that 20 years. And that's a terrible place to put vulnerable people in when it can be avoided. Because we all look at the vaccine efficacy results and we say, great, 96% efficacy. Well, that's great unless you're one of the 4%. And then you know that your experience with this is going to be like any one of these wee Tanzanian kids when they get hit by malaria, that you're one of those vulnerable individuals. Okay? So it's just a terrible situation. It should be avoided. Every country that can get out of these situations sooner or later makes those decisions, and we need to be equally clear about COVID. Next, please. So on to some encouraging stories. Measles actually originates from livestock virus, and it crossed over into humans sometime 2,500 years ago. And that virus is called rinderpest, which has a really entertaining Irish involvement. So we'll talk about it next, please. Thank you, Ben. So rinderpest is kind of similar virulence to Ebola, but for cows. And it's pretty nasty stuff. And so none of us know about it because it doesn't exist anymore. Next, please. Now, the Irish involvement starts with J.H. Patterson. Rinderpest doesn't affect humans, but starving lions certainly do. And there's a fabulous movie associated with this, but there's actually a plague of man-eating lions. If you go to the next slide, please. There are some lions dealt with by this Irish engineer who are actually the only animals to have been named in the UK House of Parliament, who basically stopped a railroad for a couple of years. Next, please. But a more direct Irish involvement in the rinderpest eradication campaign was an Irish vet who went to Tanzania in the Second World War and basically boiled down cows, put the juice into beer bottles and shipped them off around the country, vaccinating every cow in East Africa. And eventually, next please, you end up with this. So this is 2001. This is what was thought at the time to be the last case of rinderpest. I think there was another one in Mauritania a couple of years later. But the whole point is the last case was a buffalo. So there was an animal reservoir and all. It was still eradicated. So it just goes to show you what's possible if you set your mind to something. Next, please. And so the world has a global rinderpest action plan for the post-eradication phase, which probably looks quite like Australia's pandemic response toolkit that it had, in the freezer when COVID hit. Next, please. But, rinderpest is relatively cooperative for a number of reasons. So let's look at a slightly more difficult virus, which is similar, which is foot and mouth disease, which we're familiar with in this country. And it's pretty nasty stuff, but it isn't as consistently virulent. So if we go to the next slide, please. So one of the challenges with it is the same one we face with COVID, is that not everybody gets really overtly sick. Whereas with something more virulent, it's very easy to follow the chains of transmission and shut them down. Next, please, Ben. The other problem with foot and mouth is that you're not dealing with one virus. And foot and mouth goes beyond having variants to having what we call serovirus. And what those are basically, for the immune system, they look like totally different viruses. And so one vaccine doesn't cover them all. And these are much more diversified than anything we've dealt with for COVID so far. Next, please. And that's very similar to dengue. So there are human examples. And, if I think where COVID could go if we let it proceed down that evolutionary trajectory, dengue is the one I think of because there's also multiple serovirus and it causes regular, sporadic, very, very serious epidemics that overwhelm hospitals. Next, please. But, even for foot and mouth, most of the world is foot and mouth free, despite all those challenges. And so, it's amazing what's possible if we use the tools that we actually have. Next, please. Now, I've been accused of being a very optimistic individual, which if that's the worst thing people can say about me, I'm okay with it. I've been told we're all living in a fantasy. And, if I stand accused of being solution-oriented and, going after things, I'm very happy with that. And that's because I've been mentored by some of the best. I've been very lucky. But I also have a habit of saying it like it is. So if we go to the next slide, please. And I've seen pandemics that genuinely could not be stopped. By the time we got our funding and, ethical approvals and on the plane and flew off to Haiti and got busy in Tanzania, the Zika pandemic had come and gone. And we knew we were basically working towards the next outbreak of Zika in something like 20 to 30 years from now. The good Lord himself could not have stopped the Zika pandemic with the technology that we have today. Next slide, please. And I also work professionally with malaria. That's my usual focus. And I just want you to look at the reproduction numbers on the left-hand side, okay? And I'd like to point out all the points on the top right-hand side. That's where I lived, right? That's where we raised the kids. And malaria has reproduction numbers in the thousands. We think we've achieved a lot by achieving 99% suppression of malaria in Africa, but it's nowhere near enough. We're only halfway there, and I'll still be working on this when I retire. We've got a long way to go, and I'm not shy about saying that. Next slide, please. And I certainly did say this. I was in the room when this happened, and I was very quick to point out to these folks that, that it might take a while to get there, to put it mildly, even though they were paying my salary at the time. So honestly, if it wasn't possible to eliminate COVID, I would tell everybody. And I just want to make sure we deal with this before we end up with something where I have to say, I don't know. Next, please. So, and we do know it can be eliminated even without vaccines. Now we've got vaccines on our side, so let's get on with it. Next, please. And I think we should really get on with it. And here's the reason why. I think we've gotten away much lighter than I was expecting in terms of potential animal reservoirs and large outbreaks through animal populations. But the animals have left their imprint on the genome of the virus, and that's not good news. There's all kind of animals have changed, have caused an evolutionary trajectory that has changed the spike protein. Next, please. But that's not the biggest issue at the moment, I think. So this is a picture of the spike protein and its mutations as they arose in a single individual human being. Next, please. And here's how this happens. This virus is ruthless, and one of the tragedies is that it exploits our best side, our compassion. And at the moment, and also our medical technology, at the moment, there are more immunocompromised people on this planet than there ever has been by a huge margin. Medical technology is so much better. Medical care in many countries is so much better. And we also have HIV around. So what you're seeing in this graph is the evolution of multiple variants in a single chronically infected, immunocompromised individual who sadly passed away on day 102. And what you see is basically because this poor person didn't have much of an immune system themselves, they borrowed the immune system from somebody else. So you can see about halfway in, they had somebody else's antibodies poured into them in the form of convalescent plasma. And then you just see, a whole bunch of new variants with 6 new mutations suddenly jostling for space inside this person's body. And this is what we call an accelerated evolution process. So, there's lots of reasons to care for our vulnerable people, and this is one of them. There's lots of reasons to make sure that our vulnerable friends and neighbors do not pick up COVID over the course of their hopefully long lives. Because, next slide, please. This is where new variants come from. And this is the family tree of COVID in that hospital and the surrounding region. And all those extended branches that you can see, the longer the branch is, the more mutations are. Those are individual chronically infected individuals who couldn't clear their infection within 2 weeks. And that's a tragedy for the individuals. It can also be extremely dangerous for all of society. Next, please. And that's where variants of concern come from. This is the very similar family tree for P1, which we know emerged in roughly October 2020 through a similar accelerated evolution event, and still has Brazil on its knees. I can tell you the conversation of my wife with her father in Brazil are pretty tough these days. Next, please. Yeah, next please, we can skip that one. Thank you. So yeah, I think it's keen that we deal with these and be shut of them. And this is an outbreak amongst vaccinated healthcare workers in India, where the Delta variant emerged. And what we see is that there are vaccine breakthroughs, there are outbreaks amongst vaccinated health workers. It's not enough to sustain itself in the absence of, unvaccinated people, but it sets down a marker for us to be wary and to make sure we just shut down the factory for these variants. Next, please. So, the things we need to do are obvious. It's vaccines plus all the other things we know how to do and taken in a preemptive, aggressive way. But we also need to be mindful of things like travel. Hopefully, we'll never see travel-related outbreaks like this again. And I'd actually be quite comfortable with kind of herd immunity airports with fully vaccinated staff and fully vaccinated travelers if everybody did test before and after. Because next, please. We should be able to reel those in like we do for. I'll skip that one actually. The badger's a bit of a side detail. And so we should be able to reel this one in like we do for measles outbreaks. Next, please. Now, to do that, we need to get into a different place to the place we are today. The place we are today is that we have Delta in this country. And if I want to know more about that, I have to go on to ISAG, an external repository for genomic data. And I know that it's in Dublin, but Dublin's a big place with 1.5 million people. So is Cork, and you have known that it's in Limerick. Doesn't tell me much. Next, please. Whereas if I go to Australia, where they've got almost no cases, then every single location where something is going on, I know where it is. Next, please. And I know if I was at that mall that I need to go and have a test. And there's a little one I got from Niall Conroy showing how they alert people to which toilet was visited by a confirmed case. So if you visited that public toilet in Queensland, in Brisbane, I believe, then you need to go get a test, and you know that, and that's public information, and we don't have that here. But here's the big danger. Next, please. The problem is that if I take all those cases of new variants and I put them on a map, I can see where they are. And if I get one sequence that tells me this is a nasty variant, I can pretty much guess that everything else I'm seeing is also this nasty variant because it's the only outbreak I'm dealing with. That's the Australian situation. As soon as they have it sequenced the same day, they know everything they're dealing with is probably this new variant. Whereas in Ireland, it's lost under an ocean of all the other stuff that we're dealing with. And so in Ireland, if I said there's an epsilon, there's an outbreak of epsilon or theta somewhere in Carrick-on-Shannon, and I would say, well, where's the rest of it? How do we know it's not disseminated halfway across the country? The short answer is I don't know, because I would have to sequence every case in the country, and that's going to take 2 weeks, and that's too long. So we need to get out of this situation. Next, and I think last slide. So, there's lots of reasons to eliminate for everybody. One of the reasons is that, Ireland getting itself out of this endemic situation is a bit like when you're on an airplane and the oxygen drops down, and the instructions are to put the gas mask or the oxygen mask on yourself first and then look around after people around you. And Ireland needs to get out of its epidemic. Europe needs to get out of its epidemic, because this thing won't be over until we're looking after everybody. And all these little guys, these are our neighbors and our friends. They just happen to be far away. And next slide, please. And that'll definitely the last one. And, the reality is that COVID is not the first pandemic. It's not the only big endemic or, disease we're dealing with. COVAX is nothing new. COVAX is just a rebranded, specifically targeted version of Gavi, the global vaccine fund for equitable vaccine distribution. And then the global fund is specifically targeted towards the big three, HIV, TB, and malaria. It's the best value for money in the world, and yet we only put $4 billion a year globally into it. The whole world puts $4 billion a year into it globally. It saved 38 million lives. It falls way short. We have about half the budget we need to do the basics on malaria. And just to put things into context, Ireland spent twice as much on gambling last year than the world put into things like TB, HIV, and malaria through schemes that exist, that we've ignored, that we are not funding. And we need, once we get out of this, we need to remember our humanity and get back to dealing with all the pandemics. And we should learn from this experience. So, okay, that's me. I'm going to stop there. And back to you, Aoife. Thank you.
Thanks, Jerry. Yeah, that was very interesting. I think it's important to see the comparison with other infectious diseases. And I think the example of measles is a very relevant one, because we see that is an endemic disease. Outbreaks happen, but they don't impact on our daily life the way COVID is currently impacting on our daily life, because we have eliminated it from the country. When it comes in, we have protocols to react. And it's like that map you were showing where you had a lot of dots and only a small number of dots. It's when an outbreak happens in the background of there not really being much going on, then the public health can quickly react. They can tell what's going on. They can know if it's something new. Whereas in the endemic situation, it's just an overwhelmed scenario. We have a few questions that have come in, and we'll take a look at these. So one of the questions is, does living with the virus mean that even if everybody was fully vaccinated in Ireland tomorrow, we'd still be wearing masks, social distancing, hand washing? How do we get back to normal? So, Jerry, would you like to take that question? Maybe Anthony as well?
Sure, I'll have a quick crack at it. I think it would be very much like well, living with the virus, I think we all know what that looks like at present. And if we allow it to persist as an endemic form, it will be a lower grade, slower endemic pattern of transmission that will slowly pick off individuals, rather than, pandemics and epidemics, they run fast, but endemic transmission is slow and steady, or sporadic, every few years. But if we talk about elimination, you're basically doing what Israel is doing, but you keep the masks on. You're just a little bit more patient with all those complementary interventions for a few more months until it's gone. And if there's any sign of trouble, you just put the masks back on. So at the moment, Israel is just, has realized that they've outbreaks in schools. The masks go back on. Some of the restrictions go back on. Once they've finished vaccinating all their kids, then they will ease off and see how it goes. And if there's trouble, they'll react and respond. But it will be like those measles responses that we do here in Ireland. And there's no need for any panic. And then we can all leave this as a job for public health physicians. Poor Anthony and company will be very busy. The rest of us will get back to our normal lives, except for a few years more. We'll have to have our COVID passes and our tests going into and out of airports, but we'll get most of our lives back. Maybe, Anthony, would you like to comment?
Yeah, one way to look at it is there's a constant comparison between COVID and flu. And the reality is that every winter, the Irish Health Service creaks at the seams under the pressure of flu and other respiratory illnesses. And that's been going on and getting steadily worse for the last 20 years. So we have a substantial number of people die. We have a substantial number of people who are sick. We have very high healthcare costs. COVID is like that, but it's much worse because the death rate from COVID is something like 10 times the death rate from flu. The underlying illness is more severe in most cases, and a substantial proportion of people have long-term effects. Now, long-term effects after viruses are not new. We have a proportion of people have quite long-term effects after flu, for example, but COVID, the long-term effects seem to be more common and they do seem to be more diverse. So if we go for endemicity, what we're saying is that every winter the Irish Health Service will be on its knees, except more than it is at the moment. We're saying that a substantial number of people will die. We're saying that an unknown number of people will have long-term health effects from COVID, and that we're okay with this. And I don't think we should be okay with this. I really think the comparisons between influenza and COVID are seriously mistaken. It's unlikely that the health services will be overwhelmed in the way that they have been twice. We have enough people vaccinated, enough of the older, more vulnerable people vaccinated to probably prevent that. But even at 95% vaccination protection, there's still a lot of people who are going to get seriously ill. And some of those people will be substantially immunocompromised people like me, who are potentially going to be very difficult to treat. Some of them will be people who will be elderly and frail and will just die early. And none of these are desirable. So we have a choice. Why would we? No one would choose voluntarily to live with COVID. So if we have a choice about living with COVID, my vote will be for choosing not to live with COVID. We've had 15 or 16 months of living with COVID, and it hasn't been much fun for anyone.
So I think we see, though, the conversation in the last few days, we've heard a discussion about, so what is the acceptable number of deaths? You've kind of touched on it there, that people are kind of saying if it was similar to flu, that might be acceptable. And that's like, we live with it in that sense, like we decide to accept a certain amount of death that's happening. And also that I think people think of it as something that's going to be very much in the background. And, that vaccination is really going to protect the majority of people. People have also been talking about, the models that we heard about from NEFIT yesterday, when they were talking about, what are the prospects over the next few months, which is before that we're all vaccinated. So we have a certain fraction of people have received their full vaccination so far, but still a huge number have not. And, so in terms, there was a big reaction, I think, to the models the projected models from NEFIT. But as James said in his presentation, it's not dissimilar from what we're seeing in Scotland. So, arguing over the parameters of that model, it could be that some parameters might be slightly adjusted, but I think the message is not a surprise. So this expression of surprise is a bit strange, first of all. But, when the government are saying live with COVID and live with a certain amount of death, I think they need to be upfront about what they deem acceptable. And, is there buy-in from the public on that? Do they agree with what's an acceptable amount of death from this, when there is an alternative, of course, of getting rid of it? Anthony, what do you think of I don't know if you had a view on the models that were presented, the bits we heard about NEFIT's models, and what do you think of them?
And the models are not that surprising, and they do reflect fairly accurately what has already happened in Britain. And when you look across different parts of Britain, in some places, the number of cases has risen more sharply, and in some places it's risen less sharply. But practically everywhere, the number of cases, the number of deaths, the number of hospital admissions, all have gone up. So, that we don't know what's going to happen in Ireland, but NEFIT's scenarios are somewhere in the right space for what's going to happen here. And in a sense, it's about saying, well, this might happen. Do you want it? Are you willing to put up with it? In terms of challenges to the health services, everyone in the Irish health services will tell you the same thing. The Irish health services are brought to their knees every winter. Now, there's a very good set of questions to ask about why. Why do we have a health service that's so fragile that we effectively stop every winter? But that's another day's work. But there's no doubt in my mind that if we allow endemic COVID, that what happens now in the winters will be substantially worse. And I think that's worth avoiding, because I'm not sure. Our health service needs to be restructured, but I'm not sure that as currently constituted, it can cope with what's likely to happen. We have waiting lists out the door now for practically everything. Outpatient waiting lists, inpatient waiting lists for semi-urgent treatment, all stretching longer and longer and longer. And COVID is not going to help with that. So we have endemic COVID. It will make it much harder to start making a dent in those waiting lists.
Yeah. And one thing that struck me was just over the last couple of days, hearing so many politicians express surprise at the models and the projections when, like, we've been warned since April by people in the UK about this was coming and this looked bad. So in April, they said this looks bad. Don't let it happen to you, and try not to let it happen to us either. They were trying to warn their own government. Then, in more recent weeks, we've seen it increasing there, and it's been looking bad. And this expression of surprise is what shocked me the most. I mean, how could they be surprised at this point? And then I really sympathize with the people whose businesses now can't open, because those people have not been able to work for such a long time now. And the Dublin pubs haven't been open since March. I mean, except for the ones that could serve food, March last year. And there are things that could have been done to prepare for this. As we've said all along, lockdowns are not the way to deal with this pandemic or any pandemic. Lockdowns are to buy time to put other things in place. We've mentioned previously ventilation. You were mentioning there public health. In Jerry's talk, he was talking about all of the public health interventions that you can do in the case of measles. And why haven't we done these? People are getting angry at NEFIT today. They're getting angry at models. I feel more angry that we haven't prepared for something that was actually quite predictable. So this is it's just me ranting.
Yeah, I mean, I feel angry too. Sorry, Jerry.
And if I could comment on that briefly, Eva, I totally agree. And people use terms like evolution in a loose way. And that's just wrong in relation to pathogens. I think, and a lot of people who are very familiar with risk management, they're used to dealing with regular risks. And like in my line of work, what I deal with is normally regular risk management. But we have a special category for risk management of genuinely catastrophic outcomes, society-wide, all that kind of stuff. So now, what's unpredictable about a new variant? Nothing. What's unpredictable about continued evolution of a virus that's allowed to persist? Nothing. What's the worst case scenario if you wanted to select out evolution? You wanted to select out new variants. That's vaccine coverage that's high, but not high enough, and not complemented by all the other things we can do. That's where you really put the virus in a tight spot, but you don't finish it off. And that's how you get your evolutionary bottleneck. And so the way we manage those risks just requires a totally different mindset. Now, I understand why in Ireland, emotionally, we found that difficult to deal with up to now, because we've never seen it before. But if you have seen it, that's why, I mean, myself and so many malaria people are now working on COVID when we already had our hands full, because we do recognize it actually jumps the priority list. And I never thought I'd ever do that. So we need to manage this risk based on what we know about biology and what is extremely predictable based on science that was already established in the 1980s.
Yeah. Thanks, Jerry. We have a couple of questions I'd like to get to. So one is really just talking about the adjustments that were mentioned yesterday in terms of this proposal that indoor dining would be allowed for vaccinated clientele, but the staff would be a different story. And the question is it safe for the staff to be serving vaccinated customers indoors? And, is this a case of what are the risks in terms of the staff transmitting virus if we know they're vaccinated? And maybe Anthony, could you take that one?
Yeah, I mean, the situation is for staff in a restaurant. Your customers are usually there for a couple of hours. Pretty much by definition, they're not wearing face masks. They are talking because it's a social occasion. So unlike a shop where you stick your head in and pay for whatever it is you're paying, you can wear a mask, you go out again. you have quite a long period of exposure. So restaurants can do stuff to reduce the risks, primarily ventilation, distancing between tables, but the risk cannot be brought down to zero. And there's a sizable risk that staff working in restaurants will get infected, and will spread that infection further. That's why we would argue that if we're going to open restaurants, we have to vaccinate the staff. Now, there's a different question about whether we should open restaurants or not. But if we are going to do it, then it seems to me we have to take every step we can to reduce the risks in the restaurants. And that means, among other things, vaccination of staff.
And what about, we had this very good discussion last week about the role of ventilation and air quality control, because if I'm sitting beside you, of course, we might transmit to each other. But if somebody else in a different party is sitting on the other side of this restaurant, they're not sitting with me. But if I'm infectious, the virus can go up into the air and they may get infected. Or they may get infected in the bathrooms if they use it after I've used it or something like that. And, but we haven't used this time in lockdown at all to implement standards for air quality. And as Orla Hegarty was saying, if this was a waterborne disease, you'd have water quality standards, and we don't have air quality standards for this airborne disease. So this is another oversight. So what do you think about that? Is that something that should be done before opening? And that would make it, it would relax a bit the requirement for vaccination. It'd be similar, I suppose, to an outdoor setting, or would you agree with that?
Yeah, it's not. These are not exclusive. It's not vaccination or ventilation or social distancing. It's all of these things. Mm-hmm. And one of the messages from public health experience over many years is that all the bits we do are imperfect, but you win by doing lots of them. So should we improve ventilation in restaurants? Yeah, absolutely. Should we have air standards for restaurants? Yes, absolutely. But even before we have air standards in restaurants, the people who own restaurants should be thinking about ventilation. This is my restaurant. It is here. This is the building I have. What can I do to improve ventilation? And Orla had some very practical suggestions about various kinds of filtration system, various kinds of air conditioning system, and even very simple stuff like opening the windows in the bathroom. Mm-hmm. And all of this, none of this is a miracle cure. All of this helps.
Sorry, Anthony, I didn't mean to bump in. I think the key part here is to keep an eye on the difference between tactics and strategy, right? So ventilation's great, vaccines great, rapid antigen tests have great uses. They are in use. I don't know what all the debate is about. They're actually being used for sensible things. But, it's how you combine those is what makes the difference between one strategy and another. And if I was to be critical of NPHET today, and I think they showed great courage this week in putting some pretty tough news on the table, I would say the problem is not the tactics, it's the strategy. And the difference between an elimination strategy and a mitigation strategy is in a mitigation strategy, as soon as you get something to work, you use it to trade off something else. And so you're playing for a draw, and the game goes on eventually until it's penalties time, and you hope that you don't get put out. An elimination strategy says we use all of these hard and fast, finish this thing, and then have a Mardi Gras. That's the... I'm actually quite a jolly person normally. And when I think about the herd immunity, the non-pharmaceutical interventions and what it means for our lives, when I think of a restaurant, I think about an ISAG party, right? I've never met any of you guys. We'd all say we're very close friends now, but I've never met you all, and I'd love to. But I don't think we can do that as a group of friends because I know that at least two of us have serious underlying conditions, and we can't have that messy, rowdy, great night out until we know that everybody in the group is safe, which isn't just about having all of us vaccinated. It means that we know none of us can pass it on to one of our friends. And that's what it's all about. And it's about looking after each other. That's what elimination is all about. It's about looking after each other as individuals, as friends, as neighbours, and as a society, because the lack of care for vulnerable people is the Achilles heel in societies with a rapidly evolving pathogen, and people need to watch out for that and to care about our vulnerable members of society.
Thank you, Jerry. That's just so well put. And I think that's a wonderful message to take from today. We just have one last question I'd like to get to, and then we'll wrap up because we're just past the hour. And it does relate to strategy and what is the strategy. And so this questioner, so it's from Nessa Childers, and she's saying, it seems to me that NPHET are hoping for a slow burning herd immunity outcome. Could this work? And if so, are we looking in any event to the end of 2022 for any resolution? So, Anthony, would you like to start with that one? Jerry, whichever. Who was speaking there?
Yes, I mean the answer to that is it's complicated. We don't know how many people we have to have vaccinated or infected to stop the spread of the virus. Credible estimates are well over 80%, and that's with the existing strains, existing variants. Getting there, if we do it through natural infection, involves an awful lot of people getting sick, a number of people dying. It's a very inefficient way to do it. There has been concern raised in the United Kingdom about their approach to infections in schools. And I don't think that's a road we want to go down. Getting to herd immunity by vaccination, again, is possible, but it's slow because we have to vaccinate 80% of the entire population or more. Not just 80% of adults, but 80% of people. And you can get into a space with variants where actually you can't. The virus is just too infectious that no vaccine, no matter how excellent, is going to get us out of it. So why wouldn't you use non-pharmaceutical measures as well? There is this tendency to look for a magic bullet. Mandatory hotel quarantine will fix it all. We won't allow anyone into the country. It will go away. Well, it won't. Masks will fix it all. Well, they won't. Vaccination will fix it all. Possibly eventually, but eventually is a long, long time away. So none of these things on their own, I think, are the solution. I think the approach is a very systematic, strategic approach, which says this is where we're going. So we're going to control of the virus. We're going to bring case numbers right down, and we're going to try and keep them right down. And we're going to use vaccination so that once we get them right down, they stay right down. And we're going to use serious public health interventions. So if there is an outbreak, as has happened in Australia very recently, then we do something about it before it spreads to the four corners of the island, before we have to close the country again. And that's the approach for my money.
Thanks, Anthony. I think that's a very good point. Jerry, did you want to come in there?
Yeah, I think there's huge amounts to be learned from the measles elimination experience in Ireland. That really, I guess, what is the late 1960s is when measles vaccines became available. Now, it was only 2015 when we interrupted transmission, and it was 2018 when we eliminated it. But most of that time wasn't that it took decades to eliminate measles. And the herd immunity thresholds are also very, very high. I think it's a very similar story. It just needed a nudge over the line. And so, but it did take us decades to make up our minds to go after it, to set that as a target, to make that a European-wide target. And it's amazing how targets change everything. And then you're just nudging measles over the line. You're never going to achieve anything unless you define it as a target. And that's been proven across a range of diseases, that things that were considered a permanent fixture, you set a policy, you define targets, you decide, the zero COVID, zero fire, zero measles policy. And guess what? If you try, you might just succeed. And often that comes quite quickly. I mean, I was furious when Bill Gates and Melinda Gates told us to eradicate malaria, but just setting the target has allowed, I think, at least a dozen countries to emerge from malaria. They've eliminated malaria since that day, because you set the targets, you've got an agenda, you've got a goal, and you go after it. And even if you don't quite get there, only good things happen.
Mm.
Thanks, Jerry. I think this is a good point on which to end, because we find ourselves once more, it's not that we're lacking in tools, we're not lacking in options, we're lacking in strategy. And we see that again, that the government is all the plans are thrown asunder for what they had for the plans for the summer and for reopening by utterly predictable events that could have been prepared for and wouldn't have been as disruptive if other preparations had been put in place. And that's what got people so frustrated. And I think we need clear communication from our government about what our strategy is and what we're trying to achieve, because we still don't know that at this stage. But I think we've had today, an interesting picture in terms of what it means, from other examples of other infectious diseases, what it means to live with something. And it isn't necessarily a pretty picture. There's a certain assumption, I think, a general assumption that when something hangs around for a while, it becomes innocuous, but that is not necessarily the case. And given that we've seen multiple times already in a short period that this virus has evolved to become more infectious, potentially more virulent, and potentially less contained by the vaccines, you'd be a fool to bet your whole strategy on that not happening. Again, we have to use every tool at our disposal, as Anthony has said, and we need to have a strategy and we need to know what we're aiming for. And that is one of the things we're lacking. So thank you once again to Jerry and Anthony for great contributions today. Thanks to James for the situation update, which is always very useful and prepared in conjunction with Paul Dempsey. Thank you to everybody else for participating. Thank you to you for listening, and see you next time.
Thank you.